Well, howdy y'all. I want to take this opportunity to talk about the way we do CPR, why we do CPR, and try to clarify some of the features of the new modified pit crew CPR, if you will. I also want to say that this is our first installment of what I hope to be quite a few additional videos. Captain Dan Cohen is going to help us put these together. We're going to be doing these videos for our transport EMS providers as well as our first responder partners, and we're hoping that we're going to be able to get quite a bit of information out this way. One thing I would like to ask y'all to do is, if you have particular topics that you would like us to see, us address, either through us doing it or getting somebody else to do the video, please let us know. Send either me or Captain Cohen an email, and we'll see how we can address it. So the first thing I want to talk about today is this concept of minimally interrupted cardiac resuscitation. It's also called cardiocerebral resuscitation, and the idea behind this is that we want to minimize any interruptions to chest compressions, and we also want to start delaying active ventilation. So that means bag valve mask ventilation or intubation in selected patients. So what I'd like to do is just review our approach to pit crew CPR that's been modified to take into consideration this new research, as well as discuss some of the science behind it and the difference it's making in people's lives. You show up, find the patient in arrest, you begin compressions immediately. Do cycles of 200 compressions with one rescuer change in between. 200 compressions, stop, rhythm check and or defibrillation. 200 compressions, stop, rhythm check and or defibrillation, and continue that until you get to a stopping point. The initial approach to managing the airway, and we'll talk a little bit more about the exclusion criteria for this, but the initial approach should be an oropharyngeal airway to maintain airway patency and a non-rebreather mask to maintain oxygenation. We will not do any ventilation early on in the arrest. So go for 3 cycles, which should be 6 minutes, with just the non-rebreather and the oropharyngeal airway, and then begin active ventilations with either a bag valve mask or endotracheal intubation. The key thing to this is that we do not interrupt compressions, period, for either ventilation or intubation. All right, so now let's talk about the exclusion criteria, if you will. When do we go directly to a bag valve mask? So the people that we want to do passive oxygenation on, in other words, the non-rebreather oropharyngeal airway only, are the people that we suspect have gone into cardiac arrest because of a primary cardiac etiology. Well, what does that mean? So you see someone who you think died of VFib arrest, they had a heart attack, they were having chest pain and dropped, unwitnessed arrest, that the patient or the family heard a thump, they were doing fine 1 second and they're in cardiac arrest the next. So sudden cardiac death. That's the concept of a primary cardiac etiology for cardiac arrest. The assumption here is they were doing fine and had some sort of thrombogenic event. Big word for they had a blood clot that clotted off blood to their heart. They dropped of cardiac arrest. Those are the patients that we want to do passive oxygenation for. Who do we not want to do this for? We don't want to do this for children. We don't want to do this for drownings. We don't want to do this for anaphylaxis, for drug overdoses. We don't want to do this for anyone other than cardiac arrest that we think are primary cardiac etiology. Now, the vast majority of our cardiac arrests are probably going to be from primary cardiac etiology. The patients that we have the most likelihood of resuscitating are going to be primary cardiac etiology. If the patient went into cardiac arrest because of a narcotic overdose, narcotics don't subdue your heart to the point of cardiac arrest. They make you stop breathing, you go into respiratory arrest, and then eventually you go into cardiac arrest. Those patients are not the people we want to do passive oxygenation for. So anything other than what we think about as the classic sudden cardiac death, the cardiac etiology, we do traditional BVM followed by intubation approach to cardiac arrest. We still do the cycles of 200, we still do the rhythm check, shock, go immediately back to compressions. The only difference is we don't do the passive oxygenation for the things that may have started off as an airway problem. So first I want to talk about why we do the minimally interrupted compressions and why that's so important. So there have been several studies in humans and in pigs over the last 10 years or so that says there is something very important going on when you interrupt compressions. So what we found is that as you do compressions, the thing that is important is the pressure in the aorta, something called aortic pressure, not surprisingly. And that's what's important to perfusing the myocardium and to perfusing the heart and the brain, the two things that we most care about in cardiac arrest. Those are the things most responsible for neurologically intact survival. In other words, you get out of the hospital, you go back to doing your job instead of being in a vegetative state, in a coma, in a nursing home, or not leaving the hospital altogether. So neurologically intact survival is related to this aortic pressure. So what happens as you're doing compressions is with each compression your aortic pressure increases. There's a threshold above which survival is good, a threshold below which survival is bad. In other words, you need your aortic pressure above a certain point in order for you to have meaningful results, meaningful survival. What we find is one compression will increase that aortic pressure, but very, very slightly, and it doesn't get anywhere near that threshold. Repeated compressions at a rate of around 100 at our sweet spot will increase that aortic pressure. So we think about this as a pressure wave, and you can actually look at this on a graph that we're going to superimpose here. So what this graph shows is on the y-axis is pressure in millimeters of mercury, and on the x-axis is time. Now each one of these lines is a single compression. You'll notice a red line on top, and that red line is the aortic pressure. So we want that pressure to be as high as possible. With each compression, you notice the red line goes up. Eventually you get to a point where you like that pressure, it's up above our threshold. But then look at what happens as soon as you stop compressions. That line dramatically drops back down. Now the blue line underneath there is the pressure in the right atrium. That is equivalent to what we call preload, or end diastolic volume. Preload, the concept of preload is that is the amount of blood in the ventricle that you have to work with. You can't pump out any more blood than is there to begin with. At best, right now, I'm only pumping out somewhere between 60 and 75% of the blood that's in my ventricle with any particular contraction. That's a concept known as the ejection fraction. So if you measure the difference between the aortic pressure and the right ventricular or the right atrial pressure, you get some idea of that pressure wave. So what you see is as soon as you stop compressions, the red line comes very, very close to the blue line. When the red line is at the blue line, you're not going to have a meaningful chance of survival. So we want to get that red line up as high as possible. So you can see with each compression, the red line builds. When you stop compressions, the red line drops. So this particular slide was done by taking a pig, anesthetizing the pig, and putting catheters in the aorta and in the right atrium. However, we've also looked at this in patients, humans, that happen to go into cardiac arrest with these devices already in them in the ICU, and we've replicated this. What we see is that survival, particularly neurologically intact survival, increases when we minimize that drop in aortic pressure. So this graph is the whole reason that we're trying to organize our systems of care in a way that minimizes these interrupts in compressions. That's the reason we want to do minimally interrupted chest compressions. So the next thing I want to talk about is the rate of cardiac compressions. So we have spent a lot of money and a lot of time with the biofeedback devices so that we can hit that perfect beat boy. I'm sorry, that just jumped out of nowhere. Hopefully, if you actually get that musical reference, let me know. So to get that exact rate that we're looking for, why does that matter? Well, we've also done research that shows that the rate and depth is important. So we've stuck with a depth in adults of about 2 inches for a while now, but we have some new data that shows the rate is important. The graph that you're looking at now is a graph of the percent of survival, so the probability of survival on the y-axis, and on the x-axis is the average compression rate. Now, the dotted line above and below is a confidence interval, and you can basically say that that is the extremes of probability. We know that the truth lies in there somewhere. If you don't want to think about the statistics much, just look at the solid line, and what you'll notice is something that looks an awful lot like a bell curve. The probability of survival goes up with rate until a maximum rate, at maximum probability of survival somewhere around a rate of 125, and then it begins to fall off fairly quickly. So we see that if you take a target and you say you want to do compression somewhere between around 90 and 130, then you maximize survival. This graph is the reason we're aiming for our target heart rate of right around where we are. The other things we worked in here to come up with a target rate of 100 is knowing that despite a CPR biofeedback device, we are still going to increase the rate of compressions because of our epinephrine content. That has been shown over and over and over again. We bag faster, we ventilate faster, even with biofeedback. We also factored in rescuer fatigue to come up with that perfect spot. So that's really where the range is, and that's why the rate and depth matters. That's where we came up with that concept. All right, so now I want to talk about the dangers of positive pressure ventilation, the thing we're trying to avoid early on in the cardiac arrest when we do our passive oxygenation. So what is my beef, if you will, with positive pressure ventilation? So it turns out that there is a connection between positive pressure ventilation and hypotension in cardiac arrest. Now, I realize it sounds kind of weird because we're talking about hypotension in someone who doesn't have a pulse, but it turns out you can measure pressures just like the pressures we were talking about with compressions. We can measure that, and if you overventilate someone, hyperventilate them, you're actually decreasing those pressures. Now, why does that matter? Well, it turns out it matters because it decreases survival. We have actually looked at the relationship between ventilatory rate and survival, and overdoing it, by the way, is anything more than between 8 to 10 per minute, decreases survival. So I'm going to talk just very briefly about the theory behind why that is, and we have some pretty good data to support this. So what happens when you ventilate somebody? When we ventilate somebody with a bag, either through a mask or an endotracheal tube, we're doing positive pressure ventilation. That's different than how I'm breathing right now, how hopefully you're breathing right now, which is a negative pressure ventilation system. So I breathe right now because I contract some muscles and I expand the volume of my interthoracic space. That decreases the pressure inside my lungs compared to the pressure outside my lungs, and that creates a pressure differential. Therefore, air is sucked into my lungs. Another way of looking at that is, well, that's probably the best way of looking at it. Air goes down that pressure differential from an area of higher pressure to an area of lower pressure, but it does it because I'm increasing my negative interthoracic pressure. Well, it turns out that air is not the only thing that is being sucked into the center of my chest when I take a breath, when I expand those muscles and increase that volume. It turns out by decreasing the pressure in my chest, I'm also decreasing the pressure in my heart. Well, the pressure in my peripheral vasculature, the outside vessels, is higher than the pressure inside my heart when I do this. In other words, I'm sucking blood from the outside into my heart. That, again, is called preload, end diastolic volume. So by taking a big breath, I'm actually encouraging blood flow into my heart. That's why negative pressure ventilation works. In other words, spontaneous ventilation. So what happens when we now switch to positive pressure ventilation? Now the reason that air is going in is because I am creating an area of high pressure outside of the oropharynx by squeezing a bag, and that forces air into the lungs. So instead of decreasing the pressure inside and sucking the air in, I'm increasing the pressure outside and forcing the air in. Well, it turns out that actually increases interthoracic pressure, and that decreases the flow of blood back into the heart. Why does that happen? Because where we did have a pressure differential, higher blood pressure outside of the heart, lower blood pressure inside of the heart or inside the thorax with a negative pressure system, now the pressure in the chest is higher than the pressure outside the chest. So we're actually working against blood flow. So positive pressure ventilation decreases blood return to the heart. Another way of measuring that, the way we measure this, is cardiac output. So it turns out that just like with stroke volume and cardiac output that we were talking about with ejection fractions, you can't get a blood pressure if you don't have any blood in your heart. If you increase positive pressure ventilation to the point that you are decreasing the return of blood, there's not going to be as much blood for your heart to work with, even if we're just talking about chest compressions, so less blood goes out. Different authors have studied this and have shown fairly conclusively that positive pressure ventilation decreases blood return and therefore decreases cardiac output. So that's bad, and we want to minimize that. Well, how common is this? Everybody knows that it's really easy. You just count and you ventilate 8 to 10 times a minute, no big deal. We even have little clickers and metronomes to remind ourselves of this. The same author looked in a couple of different ways at the rate of ventilation of trained rescuers, EMTs, paramedics, nurses, physicians, respiratory therapists. Without fail, every one of us ventilated substantially faster than the recommended rate. What does substantially faster mean? Well, lest I delve too much into statistics and hurt your brain, which I'm going to do plenty of in just a second, this part's really easy. If the recommended rate is 82 or 8 to 10 breaths per minute, I don't think we need to do advanced statistics to see that the rate they were bagging at, 60 per minute, was higher than that, and that was statistically significant. That's actually the rate that if you videotape people during cardiac arrest and looked, that folks were ventilating. Incredible overventilation that dramatically decreased blood return to the heart and decreased survival. That's the reason we're trying to eliminate positive pressure ventilation. Turns out there are two things that we're doing here. One is the rate of ventilation, and two is the force of ventilation. So one of the things that you're going to start seeing with our new equipment is we're going to start using these red bag valves. These things are called smart bags, and they actually have a little pressure gauge on them. And you'll notice that as you squeeze too forcefully, it locks up. And the reason it locks up is it's saying, hey, that's too much pressure. The pressure is related to cardiac output. There will also be a little light, a little metronome light on there that blinks right at 6 to 8 times per minute. When that light comes on, you begin squeezing the bag. When the light goes out, you stop squeezing the bag, and you don't start again until the light turns on. That's a little metronome to help us stay on task. Doesn't guarantee it, because the literature shows even with the metronome we still overdo it, but it dramatically decreases it. And the good news is just by paying attention to this and knowing it, you can decrease the rate of ventilation. When we go back and look at our cardiac arrest, we're still over-ventilating. We're ventilating nowhere near 60. We're now ventilating somewhere between 15 and 24 times a minute, just based on our anecdotal review of the QCPR files. So we're still doing this, even though we know it's important not to. The light will help us minimize that even more. What will help us minimize that even more? By preventing it altogether. And it turns out there's a sweet spot. When is it most important to avoid this hyperventilation-induced hypotension? Early on in the cardiac arrest, when we have the highest chance of getting the patient back, of getting a good pulse back. That's the reason early on we don't do positive pressure ventilation at all. That's the reason. So we're trying to minimize the reduction in blood flow that happens with positive pressure ventilation by avoiding it altogether. All right, so now what I want to talk about is why do I think this passive oxygenation concept will provide adequate oxygenation. So we already covered why we don't want to interrupt compressions, and we covered why passive or positive pressure ventilation is bad, but what about the alternative? Can we get enough oxygen in just by doing passive oxygenation? And it turns out, yes, we can for a limited period of time. So why is that? So I want to start by telling you that we are limiting the population of patients we're doing this in. We are limiting it to patients who had sudden cardiac death. In other words, a primary cardiac etiology. Why do we limit these patients? Because the assumption is they're walking along, breathing fine, with adequate concentrations of oxygen in their bloodstream and in their lungs, and then they drop and their cardiac output goes to zero very rapidly. That's sudden cardiac arrest. That's the reason that we're limiting it to the primary cardiac etiology. So let's think about what happens to the oxygen content in the blood in the aorta and in the red blood cells, the hemoglobin in the aorta. So it's just left the left ventricle. The patient is happy. Good oxygen saturation, 95 to 100. They're breathing well. They have a good reservoir of oxygen in their lungs because they just took a good tidal volume breath. They probably took 40 to 60 years worth of good tidal volume breaths. They have plenty of oxygen in their lungs just in terms of gas. They have plenty of oxygen diffused into the blood, so the content of oxygen in the blood, and they have plenty of oxygen bound to their hemoglobin, i.e. oxygen saturation. Then they form a clot, they go into VFib, their cardiac output goes to zero. Nothing about going into VFib changes the oxygen content in the lungs. Nothing about going into VFib changes the oxygen content of the hemoglobin, the oxygen saturation. Nothing about that changes the content of oxygen in the aorta. Now that oxygen content stays right there. There's no more blood flow, so the oxygen content in the blood in the aorta isn't moving. It's not passively diffusing at a rate that's significant at all. So we have, at the time of death, we have a good oxygen reservoir in the lungs and in the arterial system. Now, how does oxygen get out of the arterial system? The arterial blood, the oxygen-rich content of the blood, goes down to the capillaries. The oxygen diffuses from the blood into the cells where it's used. And then the oxygen on the hemoglobin, where the majority of oxygen is carried, is released from the hemoglobin to essentially replenish the oxygen molecules that are diffusing out of the blood content. Then that goes into the cells, and eventually you have oxygen depleted blood in the venous circulation that then goes back to the heart and lungs and gets reloaded. So when cardiac output stops, the blood on the precapillary side still has lots of oxygen there. Now the other thing that determines how rapidly oxygen diffuses or how rapidly oxygen is depleted from the arterial reservoir is the oxygen needs of the tissue. And here we're primarily talking about myocardial oxygen, heart tissue, but you can also think about this in terms of brain tissue and kidney tissue for that matter. The two organs we really care about, though, are brain and heart. So the other thing that determines how rapidly oxygen diffuses out of our reservoir, how rapidly that reservoir is depleted, is the oxygen demand. What happens to the oxygen demand when we go into cardiac arrest? The workload of the heart goes to zero. The heart's not beating anymore. The myocardial demand drops off dramatically. Therefore, you're not seeing that pull of oxygen from our reservoir, so we're not depleting it as rapidly. Those are the basic concepts behind why we think that the amount of oxygen that's there to begin with is adequate to get us through for a while. Now, what about replenishing our oxygen reservoir? Are we able to do that with just a non-rebreather? Well, it turns out we are. How does that work? We put an oropharyngeal airway in, which obviously has nothing to do with oxygenation, but it moves the soft dependent tissues of the palate up out of the way so that we can actually have a good passage of air. So now air is able to move freely from the oropharynx into the lungs and then diffuse across. So we are creating a concentration gradient between the oropharynx, where we're just pushing all of this air by a non-rebreather. The non-rebreather is going in, creating this high concentration of oxygen, and then that air diffuses down its concentration gradient from an area of high concentration to an area of lower concentration. So we get that diffusion. Remember, diffusion is passive transport. You don't need any energy involved. You don't have to be breathing. You don't have to be forcing air in. Just by creating a concentration gradient, oxygen is going to travel down that gradient and replenish the oxygen reservoir in the lungs. That then is going to diffuse into the bloodstream. So you're going to have passive diffusion of oxygen. That way you are going to be replenishing your reservoir. Now, so that's just purely passive, assuming that there is very, very minimal air movement. Now, we are assuming that there is some blood movement because we're doing compressions. So as you're doing compressions, we're doing that to maintain blood flow. So we're bringing in some oxygen and moving it around. That's all from a passive ventilation standpoint, but it turns out it's not just passive. There is some ventilatory activity. So we are changing the interthoracic pressure by doing compressions. And we've shown through the literature that by doing compressions, it turns out we spent a lot of time talking about adequate recoil. We have an annoying little CPR device that tells you you need to recoil more. The reason is that you recoil off of the chest, the interthoracic pressure increases, that decreases the pressure in the lungs and sucks some air in. So when you're doing CPR, you're actually doing some ventilation. And that is encouraging the movement of air from this high concentration air down to this low concentration area. So you're actually increasing the amount of oxygen that gets to the lungs, that gets to the blood supply. So those four things, increased oxygen or adequate oxygenation at time of arrest, increased concentration of oxygen just from passive oxygenation, increasing negative thoracic pressure just from your ventilation, and then decreased myocardial demand, all tell us that we think, in theory, passive ventilation or passive oxygenation should be adequate early on. And then the last thing, and this is something that you may have noticed, is that you're doing CPR and the patient appears to be breathing. Those are agonal respirations, and we see this all the time, and I'm sure y'all have all seen this. You walk up to a cardiac arrest, they have no pulse, but they're breathing. Well, they're not breathing adequately, and those are agonal respirations. Well, even while you're doing CPR, the patient may still have some agonal breaths. That's going to enhance the movement of oxygen. So those are the reasons the theory says this should work.